Hello everyone, how are you? I am Dr. Shariful Halim and today I am going to talk about positive predictive value and negative predictive value in a case-based manner. So let's first talk about positive predictive value. Suppose a patient comes to you who has a positive HIV test and asks you what is the chance that he really have the disease, having that regarding that he already has a positive test result. Your answer should be give him the positive predictive value of that specific test. So that should answer his or her question. So positive predictive value is actually proportion of the positive test results that are really or truly positive. So it actually tells you the probability that a person actually has the disease when he already have a positive test result, because sometimes you can have positive test result in people who actually does not have disease. So positive predictive value or PPV is true positive divided by all positive, which are including true positives and false positives. So true positive divided by all positive results. And PPV actually varies according to prevalence or pretest probability, and whenever there is high pretest probability of a disease or high prevalence of a disease in a community, there will be high PPV. So whenever, suppose a patient from Bangladesh, so whenever you test him or her for cholera, there is a high PPV for being diagnosed as cholera patient, because cholera is a highly prevalent disease in Bangladesh. Or suppose you are testing a patient from USA for HIV, so there might be high positive predictive value for having a positive HIV test and truly having the disease in a patient with a positive HIV patient in USA. So how prevalence affects the positive predictive value? So here I have a hypothetical situation to explain that clearly. So you take a population of 200 and where the prevalence of a specific disease is 50%, and you have a test for diagnosing this disease, and the disease and the test have a sensitivity of 90% and a specificity of 90% too. So as the people here, the study population is 200 and you have a prevalence 50%, the number of diseased people will be 100 and number of healthy people should be 100, because we are dividing in 50% groups, 50-50 groups. So in our test we have said that it has a sensitivity of 90%. So as the sensitivity works with the people who are truly diseased, so 90% sensitivity means 90 out of 100 people will be true positive, and the remaining 10 who are diseased will be false negative. The true negatives should be also 90 out of 100, because you have a specificity of 90%, and there will be remaining 10 who also do not have a disease but have a falsely positive result, so those are false positives. And the PPV will be true positive divided by true positive plus false positive, so it would come out as about 90%. And now let us increase the prevalence of the disease to 75%. So the number of diseased person now will be 150 instead of 100, and number of healthy person should be 50. So the remaining 50 will be healthy and the majority or 150 will be diseased. So now as the sensitivity is 90%, so 90% of 150 people will be true positive, so the true positive will be 135. False negative will be 10% of the 150 who also have the disease, which will be 15. True negative will be 90% of the 50 people who does not have the disease, so it will be 45, and the false positives will be 5. So now PPV should be true positive divided by all positives, or true positive plus false positive. So here true positive was 135 and false positive was 5. So 135 divided by 135 plus 5, it gives you a result which is 93%. So in previous case we had a positive predictive value of 90% while the prevalence was 50%. Now as we have increased the prevalence to 75%, the positive predictive value now increased to 93%. So it should tell you or tell us the story that higher the prevalence of a disorder, higher the positive predictive value of that disorder being diagnosed in a test which have a normal or which have a specific sensitivity and specificity. So here we have another case study to clear up our confusions. So suppose a patient comes who is 55 years old, complains of urinary frequency and a 3 centimeter nodule in prostate gland, and now you suspect that this patient might have prostate cancer. So you order prostate specific antigen, and the standard range by common standard, the PSA above 4 nanogram per liter is considered abnormal. And using the standard, the test that you do, the PSA have a sensitivity or has a sensitivity of 80% and specificity of 90%. And recently published studies showed that in cross-sectional study that 10% of men at this age has prostate cancer. So the prevalence of the disease or prostate cancer in this population group is 10%. And the result of patient PSA is about 7 nanogram per liter, which is positive. So what is the best likelihood that this man has actually has prostate cancer given the PSA level of 7 nanogram per liter? So there are multiple options from 13 up to 81. So you can pause here and you can solve the question, and I'm directly going to solve this question. So here for solving it, one of the easy way would be make the number of total people that in our study, hypothetically 100, will make it a little easier. So make n 100, so it will make everything easier. So as the prevalence is 10% in the population group, so now the number of those truly diseased is 10, and the number who are truly healthy are 90. So as the sensitivity always works with the people who are truly diseased, and sensitivity here is 80%, so the true positives will be 80% of 10, which is 8, and the false negatives will be remaining 2. And of the 90% who are truly healthy, now you can use specificity equation here. So as the specificity is 90%, so true negative will be 90% of 90%, which is 81, and the false positive will be the remaining 9. Now you have the values to calculate the positive predictive value. So here positive predictive value should be true positive divided by true positive plus false positive, which is about 47%. So now you got the answer, which is 47%. Okay, so let's move forward. Negative predictive value. So negative predictive value can be established by this case. So suppose a lady comes to you for pregnancy, and now she has a negative pregnancy test and asks you how correct is her result, or what is the probability that he really does not have the pregnancy given a negative pregnancy test result. So your answer should be, you give her the negative predictive value of that specific pregnancy test. So negative predictive value is the proportion of negative test results that are truly negative. It actually tells you the probability that a person actually does not have the disease when he gets a negative test result. So NPV, or negative predictive value, is true negative divided by all negatives, or true negative plus false negative. And NPV also varies inversely with prevalence or pretest probability. So where there is a high pretest probability or high prevalence of a disease, it should lead to a low negative predictive value. So the take-home message from this lecture should be, sensitivity and specificity are fixed properties of a test which never changes, but PPV and NPV vary depending on disease prevalence. So whenever you have an increased prevalence, P has a relationship with PPV. So whenever you have an increased prevalence, the PPV increase, and whenever you have an increased prevalence, the NPV decrease negatively. So prevalence positively increases PPV. Prevalence negatively affects NPV. Thanks all for watching my video.